So untreated endometriosis, whether it has the impact. Yes, of course. So endometriosis can deplete the ovarian reserve, uh, even if it doesn't affect the quality, because we don't have enough evidence to say that. Although we think that is happening, but we don't know. So we think in general, whenever the quality is, the quantity is affected, the quality might also be affected, but there is no evidence to that. But definitely the quantity, meaning the amount of the ovarian reserve, can decline, first of all due to endometriosis itself, and secondly due to the surgery. So very important is to do the AMH before and after the surgery to see how much reserve has been affected by this surgery. It should be done very, very carefully. Sometimes some surgeons are very aggressive, and without the consultation with the fertility specialist, the decision of the surgery is taken, and then the patient comes to the fertility consultant with very, very little number of eggs because they were all stripped off during the cystectomy that the surgeon did. So endometriosis surgeries should either be done by the fertility specialist herself or himself, or they should be done with only after having the doctor having liaised with them, so that they are aware of the scan findings, they're aware of the AMH, and they decide how much to do. These days, there is a new technique called Donay's technique, which is getting very popular, how to do the surgery. So rather than doing the whole cyst stripping, they cut the cap, the top, and then they fulgurate the base, uh, keeping the ovarian reserve intact as much as possible. So very, very minimal, very gentle surgery. But there is a very here that first of all, the only two indications of surgery in such patients is if there is pain, which is not managed medically well with tablets, or if the ovarian cyst is so big that it is coming in the way of egg collection. Only then surgery should be done twice. The egg collection should be done first, and the surgery should be done after that, so that most of the follicles get stimulated and most of them are, we are able to take them out and freeze them. And then if the surgery is done and the possibility of ovarian reserve getting depleted is there, will not harm the patient as much because of eggs are already frozen. Rather, it is always better if this patient is maybe not ready to get the pregnancy, but if she has a partner, she can always create all or few of her eggs as the embryos, because freezing embryos is less challenging as compared to freezing the eggs. So she or the couple can do the egg freezing or the embryo freezing for future, and then do the surgery. Recently, I had a patient last week, and she actually was sent to me for IVF by another surgeon, not a gynecologist. Generally, I do my own surgeries, or I might at least try to remain present in my surgeries if anyone else is doing. So I really keep a very, very close eye on how aggressive is the surgery, because I like to be very gentle for these patients when the surgery is done. But for example, this patient, the surgeon called me because one side there was a big mass, which was something else, maybe something sinister. And the other side, there was an endometrioma. And the interesting situation was that because of this query sinister nature of the one side, he was very eager to do the surgery. And because he was doing the surgery once, he wanted to take out the endometrioma as well, because otherwise the woman would be subjected to the surgery again. But this woman was 41 years old and had a very good AMH, to our surprise. So we decided to do the incomplete surgery. So we decided only to do the sinister side of the surgery and take out that and send it to the histopathology lab to check if it is really something wrong. But we still did not touch the other side. And obviously it was done after discussion with the patient, that if there is a need, we will do the surgery again, but the need might never arise because she didn't have any symptoms. So in the absence of pain, like I said, the only two indications of the surgery for endometriosis is either the pain, which is not controlled by the medical methods of or tablets enough, or the second is when a fertility specialist feels that this endometrioma or the cyst is coming in the way of the needle of egg collection, which is a very, very unlikely scenario, because when we generally stimulate the ovaries, they become so big that they become more accessible. So access is generally not the reason to do the surgery. So we sometimes leave very, very large endometriomas to the size of sometimes 10 to 12 centimeters unoperated if the patient is not having any symptom, because till she does not complete her family, doing any surgery will mean that we're depleting of her eggs.